regardless of where you work, you're going to have mental health patients. Every single patient you'll interact with will have some sort of mental health thing going on. 24/7, it just might not look the same as what I'm talking about.
Psych can be, in one end of the spectrum, it could be pretty laid back, but then on the other end of the spectrum, it could be highly dangerous. And there's kind of a lot of pros and cons for both sides of the spectrum, even when it regards to aspects of the job that you like or don't like. And so from your personal experience being in the acute adolescent critical care, like, what are some of the pros and cons that you experienced?
Well, one of the biggest pros is you and your coworkers get real tight real quick. Because what you do is because it's like you and 3 other nurses, depending on the size of your unit. And one of those nurses is a charge nurse. So it's like you and 2 other nurses doing floor work while the charge nurse is doing whatever that hospital system has their charge nurse doing. Because it varies from hospital to hospital. Like the hospital that I was at, the charge nurse was also the intake nurse, the resource nurse, and the staffing nurse. So there wasn't a whole lot of and obviously if the unit went to crap real quick, the charge nurse would help and respond and stuff like that. Load our charge nurses, and as someone who was charge trained, because that was the nice thing, you'd rotate who was charge. And so as someone who was charge trained, I respect that, and I hated being charge nurse. I just was I want to do patient care. I don't want to deal with the nursing world hospital politic crud. Let me go in, take care of my psychotic. I will take an aggressive psychotic or autistic patient any day over that crap. Any day, especially during the pandemic, which is when I was charged the most. I was like, I hate this. And some hospitals actually have charge nurse, being a charge nurse. It just depends on what your hospital system has going for it. So you get really close with your coworkers, and psych, the last little bit of psych has been my stories have been super dark, super ooh, but it usually is happier endings than it is sadder endings. Because in psychiatry, it's a little bit harder than than being a regular nurse, because if you don't see your patient again, it means one of 2 things. One, they're doing better. And they've made some changes in their life, so they don't need to come back to the hospital. I take that back. There's a third option too. 2, they actually killed themselves. Or 3, they moved. That's the third option. And in the years that I was a psych nurse, we were only made aware of 1 case where a patient had killed themselves successfully outside of the hospital, which, in a 3-year stretch is actually not bad.
Yeah.
I had a lot of repeat patients and stuff like that, but, it was, it got to a point where, you can get to know your patients well, and you can kind of talk with them yeah, I understand you are going through the worst moment of your life possible right now. I've had patients who everyone in their family has died except for 1 family member that they don't get along with. And then that family member ends up beating the crap out of them just because the sun rises and the sun sets. And, and they're bullied at school. Literally, I've taken care of patients that have had everything that culture justifies is, just kill yourself kind of thing, would meet criteria to do that. But the fact that they're in the hospital, either they came, because I've had cases where they called the police on themselves because they felt unsafe. Which, takes a tremendous amount of insight, depending on which patient it is. It's either it takes a tremendous amount of insight or you want a tremendous amount of attention. That's another hard part about psychiatry. But, for the times that I can think of the most, I thought of a lot of patients that did it well, and they're I need help and I don't feel safe, because if I don't have someone to talk to, I feel like something bad's going to happen. I'm going to do something bad. So you do have a lot of success stories. When you have that manic patient who, mania is 1 phase of bipolar disorder, right? So you have your super depressed episodes, and depending off is bipolar 1 or bipolar 2, bipolar 1, if I remember right, is you'll have your super big dramatic swings. So you'll have super depressed do okay, do okay, do okay, do okay, manic, hypomanic, and manic, and you're up here for like 28 for like ever. And then you'll have your bipolar 2, which is like almost super depressed, almost super manic, but you're not quite there. You know, it is rewarding to see those patients that are psychotic or manic, and you know, like they're with you for a little while, and you kind of see them like come down gradually from their psychosis or from their mania, and you know, you just get to see them be normal kids. Right? In my experience, it was kids because, you know, child and adolescents. So they're just like, it's kind of nice, and sometimes they can remember what happened, sometimes it doesn't. They don't. I can think of one kid in particular. It's like this one kid in particular, he was with us on and off for a lot because he had uncontrolled bipolar disorder. It seemed like it was maybe med resistance or the parents weren't giving meds. There was some other cultural things, and that's another whole bag of worms in terms of mental health and culture. Because some cultures are like I said, like super spiritual and like super like it's from the devil. Just bring a priest and exercise. Like, okay, you know, might work, probably won't. And then you have those people who kind of like belittle the whole spiritual aspect of humanity, because, you know, humans are, you know, they have physical, mental beings, and, you know, most people agree that, you know, we're not just bodies bodies that can breathe. And so there's, like I said, this one kid, he was on and off with us for a while, like med resistance, or parent was giving meds, and I was his one-to-one or his nurse, because he was, when I was still like an assistant and also being as a nurse, there's a couple of times where he would come in and, like, you know, he'd like come down just a little bit, and even when he was like up in mania world, like he would still recognize me particularly.
Oh,
So I was
wow.
with him so much, and like I was, for the most part, don't want to toot my own horn or anything like that, I was able to kind of like help him keep from getting restrained, whether that be talking him down or, you know, what have you, like playing ball with him or something like that, because sometimes you'll just get a ball, go back and forth, and you're just like, okay, well, you're manic, so whatever. As long as you're not like throwing bullets at me, that's fine.
Yeah.
There's a lot of rewarding aspects, especially when you get those like those kinds of cases, and like your psychosis is, like I said, when you get them on the right combinations of medication, you know, like they're not as psychotic, but they're still kind of psychotic, but they're like nowhere near as bad as when you first got them. Like there's a lot of like that good stuff that you kind of see. Or you'll get those kids that are like anxiety disorders, and you kind of come in and they go through like therapy and start like a low dose and antidepressant to help with the anxiety. Right. Meds and mental health don't always make sense, but that's a different story for a different time. You know, there's a lot of happy ending stories as well. As, I mean, you get your occasional bad ending story, but I can think of more positive endings for my patients than bad endings, I think.
Wow.
And then cons, physically it's more dangerous. You know, there's that. I'm not going to deny that there's that component that, you know, there is a real possibility that, you know, you might have a patient that overpowers your staff and comes after you. There's a possibility for that. And if that's the case, hands-on training is out the door, and you're doing whatever you need to survive. So that's one downside. You know, just gonna go ahead and throw that out there now. Second one is mental health is tricky in a sense of people are genuinely sick in mental health wards, but some people are more manipulative than others. And so you'll have some kids or people that'll come in and manipulate a situation more, and they'll paint themselves as being more depressed or more anxious, and they'll just kind of up the ante every time someone sicker than them comes in. Like I saw that happen a lot, and it's just like, no. Like you've been coming here for the last 3 years. I've known you for the last 3 years. Like, no, like this. I know this is not your baseline. You've never had these kinds of symptoms, and it just so happens that you say you can't walk when we get a patient come in that's in a wheelchair. And you were just running sprints yesterday. Please tell me how that works.
Yeah.
Like, so you have those patients that are like kind of attention seeking. And so if you are someone who's more gullible, like I hate to use that worded verbiage, but that's just kind of how it is. If you aren't able to catch a lie in its teeth, or a manipulation attempt while it's kind of fresh, like it probably won't last long in psychiatry, because you're going to get manipulated. And usually those, from what I've seen in terms of the board, like, because borderline personality disorder, you guys want to look that up. I don't really want to go into the details of it, but you get a lot of those kinds of patients in. And, you know, those patients, the reason they have those attention-seeking behavior is because they're probably beaten at one point in time or abused in some way, shape or form. They have a form of legitimate trauma that happened to them, and this is them surviving.
Yeah.
Like that's another weird part about psychiatry is like when you get those kind of personality disorder kind of things, it's like this is how they survive because this is how they had to learn how to survive.
Mm-hmm.
If they hadn't been put in this situation in the first place, they wouldn't be like this. So that's like an interesting piece, and like that was one thing that I liked specifically about working with kids and teenagers is they're at that spot where, you know, because like teenagers, you know, they're like stubborn or whatever, but they're nowhere near as stubborn as like a 40-year-old guy. Like, let's be real here. Like that dude that gets that knee replacement and is told to walk 24 hours later, he's like, I ain't getting up, my knee hurts too much. Like, I get it, dude. I saw your surgery. It hurts. But if you want your knee to keep working, you need to get up. Like, but teenagers is like, what's interesting about teenagers, especially if you can talk their language and kind of be at their level in a sense, they may seem like they're ignoring everything that you're saying, but they actually are listening. And like, you know, they do pick up bits and pieces of what you're saying. And, you know, sometimes they make some life choices that are smarter and better than not. And sometimes they don't, you know, just kind of depends on your patient and the situation that they're in. That's another kind of a big con. And then I mentioned earlier that that psych nursing is new. Good psych nursing is new. I'm not saying that psych nurses before were bad. It's just the understanding that we have of psychiatry now is different than it was even 15 years ago.
Yeah.
It's much, much different. Like we've made significant strides in kind of understanding where like schizophrenia is and how that works. In some cases, not all cases, like there's quite like it's like a 50-50 shot depending on what kind of schizophrenia you have. Like we're making progress in mapping the parts of the brain so we can figure out how to do different types of treatments for like major depressive disorder, anxiety disorders. We've made these massive medical gains in the nursing world for psychiatry. And with that being said, is we are still making a lot of gains. So there's still a lot of interesting characters as psych nurses, because you have those old school thought, I hate to say like those like older school battle axe nurses, you know, who like are great nurses and take care of their patients, but it's just very different than like a newer person who's gone through nursing school more recently, who knows kind of what that is. I'm not saying one is better than the other by any means, but it's just you'll have like that person. Like I can remember when I first started as a nurse, I had the nurse that had been a psych nurse the longest, like the absolute longest nurse on the unit. Like she'd been a psych nurse for like 40 years, so like double the amount of time I'd been alive. So she taught me all these really cool tricks of the trade, and you know she also taught me a lot about. Like she also did a really good job of integrating, you know, more modern psychiatry practices into how she does her assessment. So she did a good job, and you know, I hope she's doing well still. I know she retired, but yeah. So with that being said, is you'll get a lot of policy changes. I can say, especially with the pandemic, I wasn't wearing an N95 at all. We were wearing surgical masks, and that was really it for a pandemic. But our patients had to be tested and test negative for COVID. And, you know, sometimes they wouldn't get tested. What am I saying sometimes? Most of the time, they wouldn't get tested before they came to us. So we would have to do the tests. And then the moment you find out they're positive, you're like, well, crud. Ship them down to somewhere else. So you have a lot of different policy changes, and you have a lot of different streams of thought. There's even different streams of thought within psychiatry as well, because especially when you're collaborating with psychology, because there's a big difference between psychiatry and psychology. Psychology, the easiest way to put it is psychology is more therapy based, where psychiatry is more medication based. Like that's the easiest way I can put the difference between psychiatry and psychology, but they both deal with this. It's just the different schools of thought. So even with that, it creates this very weird atmosphere. Like I can remember working as a psych nurse, talking with some of our psychologists. I'm like, you want me to do what for my patient? Like, excuse me? No, I'm not going to let them do X, Y, and Z on the unit because it's against our policies, and it's also extremely unsafe. And in the context of being in an inpatient psychiatry unit, like it would have been completely safe if it was an outpatient, if they were not in the hospital kind of thing. And so that's an interesting piece to kind of work with as well. And it can also be a really big downside, especially with all the research they're doing on psychiatric meds now. I can remember a couple times where we gave IM Zyprexa, and one of our doctors like, you can't give Ativan yet. I'm like, why can't we give Ativan? It's like, well, it may suppress the respiratory rate. I'm like, well, we know Ativan does that. And they're like, they would specifically say you can't give Ativan IM within like 30 or minutes or an hour of IM Zyprexa. I'm like, because it's like, it's got a higher chance that it's going to suppress the respiratory rate. I'm like, Zyprexa doesn't work like that, though. I thought, like, it completely binds to other different parts of the body that don't have anything to do with breathing rate, from what I remembered in school. But then I guess they've been doing these studies and stuff like that, and they saw that the IM form of those medications can interact differently than PO versions of those medications. So yeah, it's weird. Psychiatry is a whole bunch of different kinds of weird, but in a fun way and a confusing way, all at the same time. So yeah, those are some of the biggest. So it's more physically dangerous. You got to know your limits, and then it's ever changing. Which, I mean, nursing world is always ever changing, but it seems a little bit more so in psychiatry from what I've seen. But yeah, and you also, just as a forewarning for anyone considering psychiatry, you have to be willing to just ask a straight up question, like, because when you do your assessment, you have to assess your suicidality. You have to be comfortable with asking the question, hey, do you want to kill yourself? Like, you have to be okay with asking that question. You just can't be like, see, if the kid or your patient sees you're kind of weird about that question, they're going to get kind of weird about it, and there's going to be this weird awkwardness between you and the patient. They're not going to be truthful about what they're actually experiencing, and it's not very effective. So you have to be just very blunt and straightforward, obviously not sounding like derogatory or anything like that, but you just have to be very, yeah, this is my assessment. I need to know these things so I can know how to help you the best.
Yeah.
That's just more of a forewarning for anyone considering psychiatry and their assessment style.
Yeah, it's nothing shameful or anything like that. It's just, to be honest.
Yeah, I mean, because honesty is, if people were honest with how they felt, they might have not made it to the psych unit in the first place.
And I know some people might be worried that it could hinder their ability to transfer to an acute aspect of hospital care that's not psychiatric, but you yourself experienced transitioning to a different unit, correct?
Mm-hmm. Yeah, I work in the ER now at a completely different hospital system and a completely different area. And actually, a big reason they hired me is because I have so much mental health experience. Because working in the ER is more so than maybe some other units, you'll get a lot more mental health cases. Because when you work mental health, you kind of learn how to deal with tweakers and other drug users who are high, because you'll have patients that present like that, but they aren't actually high off of any substance. It's because they're psychotic or manic. Substances may have caused them to become psychotic or manic, but this totally different point. And mental health is ever growing and ever increasing. So it would be a use. I would say that's probably, if it's your first job right out of nursing school, it might be a little hard for you to transfer out because you will lose some skills. But because I've been in orientation with this hospital since January, I've been able to pick up restarting IVs, doing ABGs, all that stuff. And, physical assessment is, physical assessment that gets ingrained in your brain because that's your whole first year of nursing school. But, I wouldn't worry too much about that at all, especially if you're transferring to like an emergency setting or public health. Oh my gosh, public health, like your big thing is working with homeless people.
Yeah.
About 85% of your homeless population has a mental health problem. So, yeah. I would say don't worry about it. People will take you and they will actually thank you for it, because they'll be thankful that you have that experience, because you know how to deal with the patients that no one wants to deal with.
Yeah. Well, do you have any other pieces of advice for nurses who maybe want to consider psychiatry or psych nursing or anything within the spectrum of mental health?
Well, know this, regardless of where you're working, you're going to have mental health patients. Every single patient you'll interact with will have some sort of mental health thing going on. Whether they have an actual diagnosis of a mental health disorder, or if they just feel really crappy because they are in such a bad spot in the ER or your med surg unit or your ortho unit or what have you. you will be working with mental health 24/7. It just might not look the same as what I'm talking about.
Yeah.
So I learn what you, for those of you, if anyone's listening to this podcast that is in school, learn everything you possibly can from your mental health professor, because those practices that you can learn from your mental health professor, assuming they're a good one, will bleed into your normal practice of nursing, so much so, like active listening. Oh my gosh. Like, I'm sure we've all been like, they don't listen to me. And like, but if you're like doing those active listening things, your patients, even in the real, like in regular nursing world, like your patients are you might see a little bit different of an outcome with your patients, with you personally, like in the rapport with you. And, you're going to have that difficult patient, but if you're able to kind of reiterate and kind of help them rationalize things, they might change their tune at some point. So yeah. And for anyone considering psychiatry, it's great. Just know it is not for everyone, and there's no shame in that. No shame in that at all. Like if you think you're interested in it, great. See if you can shadow, or if you're in a hospital that has a psych unit, see if you can float to that unit, see how the staff interacts with the patients, the staff interacts with each other. Because if you have bad staff around you, it's going to be a bad day for you at that job. As I'm sure you can think of, like, you have your favorite nurses you like to work with on a unit, right? And if those nurses aren't working, you're just like, oh, it sucks. Yeah, it's the same with psychiatry, except those ones will actually keep you from getting punched in the face. So there's that. But yeah, that's what I can think of at the moment is, feel it out, take a look at it, make sure that is what you want to do. I'm not saying like you have to know it now, like, and if you go do it, you try it out, give it a year. If it's not your fit, it's not your fit, and transfer out somewhere else in the hospital system. It's not, no shame in that. No shame.
Life is a winding road, no telling where it goes.